Now we are going to the next session, and I'm honored to introduce Professor Antonio Ceriello from Italy. The lecture titled Metabolic Impact of Ketone Bodies Production in Relation to Diet and Medications. Professor Antonio?
Let's go directly to the topic. And you see that ketone bodies are physiologically produced in human metabolism. And there are several ketone bodies, but probably the most two interesting are the deoxybutyrate and acetoacetate. You know that there is a way through which ketone bodies are used instead of glucose to produce energy, going to the same citric acid cycle. So at the end of the day, ketone bodies are an important source of energy production. But also we have some specific condition producing an increase of ketone bodies. And for our interest are particularly important the diabetes itself and also the condition of fasting. There are some pathological conditions which can lead to increased production of ketones, and one of the most common, unfortunately, is diabetic ketoacidosis, which is produced when the insulin deficiency is absolute or relative. So when insulin does not work well, the body is overproducing ketones in order to replace the action of insulin to produce energy, and this leads to diabetic ketoacidosis, which is a very dramatic condition, as you certainly know. But there are some pathways which indirectly modulates the ketonemia, and there are some mechanistic evidence from preclinical models in which direct and indirect signaling mediated by ketone bodies. You see here just a number of them, and you see there are some direct influenced and some indirectly influenced by the ketones. And you see but that this activation of these pathways are also related to some pathophysiological condition. For example, the gene expression, to the lipid metabolism, to epilepsy. What is really of relevance for us is the possibility to increase inflammation, as we will see soon. And this is why ketones can have a very potent anti-inflammatory effect, because they can influence through the activation of these three different pathways, the production of metabolites of inflammation. But of course, what is also interesting is that there are some physiological effects of ketonemia, and mainly this evidence is coming from preclinical models. There are some unknown mechanisms, for example, that leads to a decrease of appetite or to an increase of inflammasome, and also to food anticipation, while we know that there are also some epigenetic change, the activation of a decreased activation of sympathetic nervous system. As you see at the end, there are some very important effects at the level of cardiovascular system. For example, an increase of vasodilation, a reverse cholesterol transport, neuroprotection, and so on. So it seems that a small increase of ketones can be helpful in preventing atherosclerosis, inflammation, and so cardiovascular disease. What is well known is that there are some dietary intervention which can influence ketonemia. And one of the most prominent and very well known is the so-called caloric restriction, which can lead to ketogenic regimens or also intermittent fasting situation, intermittent fasting, or fasting mimic diet. You on the right side of the screen, you see what happens when you have, for example, 1 day fast compared to a normal eating habit. And there is a flat situation of glucose, while occurs at simultaneously there is an increase of ketones. And also when we have a time-restricted feeding, for example, 18 hours of fasting every day, there is an increase of ketones according to this situation. So the way through which nutritionally we can influence the ketonemia are mainly the caloric restriction, fasting, or particularly relevant recently, according to recent evidence, is the intermittent fasting. And we have also evidence that this is accompanied by metabolic and anti-inflammatory effect of fasting. You see this in this cartoon, how an increase of a small increase of ketonemia according to the fasting situation can improve all the panel of inflammatory or risk factors for cardiovascular disease. And also, there is an interventional trial on this. There is this 2 years randomized clinical trials showing that a caloric restriction can lead to a significant improvement of the cardiovascular risk profile, including systolic blood pressure and influence on HDL cholesterol. So, fasting condition can help to improve the cardiovascular risk at all. But also, this is why today we are paying so much attention to the ketones, is that also we can induce an increase of ketonemia with through a pharmacological agents, and particularly using an SGLT2 inhibitor. What is relevant, you see here, is that we can distinguish between an acute or chronic dosing. An acute dosing of SGLT2 inhibitors does not seem to be really relevant in increasing the ketonemia, while the chronic dosing, so the chronic consumption of these drugs, can lead to an important increase of ketones in the bloodstream. And we have evidence that this is true for almost all the SGLT2 available SGLT2 inhibitors, and for certainly is true for the class of SGLT2 inhibitors. So, may we link this effect on ketonemia of SGLT2 to the proven benefit on cardiovascular and renal system in diabetes? You know, we have evidence that this is just a meta-analysis confirming what I'm going to say, that this, according to the outcome trials, we have evidence that SGLT2 inhibitors are particularly efficacious in decreasing the risk for cardiovascular disease and nephropathy in people with type 2 diabetes, particularly in the secondary prevention more than primary prevention. And one of the most accepted hypotheses is that the use of an SGLT2 inhibitor can switch the metabolism from the use of glucose to the use of ketones, because this produces an increase of ketonemia, but also leading to an increase of use of ketones to produce metabolism. And this seems particularly important and relevant, not only for all the cardiovascular disease system, but particularly for the heart, because we know that the use of fatty acid, which at the end of the day means the use of ketones to produce energy, is particularly efficient in the heart. And This hypothesis has been tested in the heart isolated from diabetic mice. You see here that is there is a shift in in using glucose instead ketones instead of glucose to produce energy, leading to some benefits to the at the level of the heart of diabetic mice. But also we can hypothesize another pathway through which ketones produced by SGLT2 can be beneficial, and this is the so-called inflammatory hypothesis. Because as anticipated, an increase of ketones can decrease the inflammation and activating the pathway I described before. And this hypothesis has been tested also in our lab, as you see some results of our work, suggesting that really when SGLT2 inhibitors increases ketones, they can act in decreasing the inflammatory seat condition in not only in a basic research system, but also in humans. You see here that there are at least a couple of studies comparing the use of the SGLT2 to other treatments and showing that there is an increase of ketones leading to an improvement of inflammatory profile in diabetes. And we know today, this is the last, in my opinion, frontier of pathogenesis of cardiac complication, is that the existence of low-grade inflammation can impact on the heart and kidney complication in diabetes. This is a very complex scheme. I will not go in details, of course, but you can have an idea how this, the existence of low-grade inflammation can impact in the development of these two important diabetic complications. And we also in this case, we have in human studies showing that this possibility could be true. You see here that the anti-inflammatory strategies can impact on the heart failure in humans. You see here that in these intervention trials, when there was using an anti-inflammatory drug, you can also achieve an improvement of the heart failure. So in conclusion, ketone bodies are produced by the liver as an alternative source of energy in the tissue when glucose is low and fatty acid oxidation is promoted. However, high ketone concentration are associated with ketoacidosis. You know, this is a very dramatic situation, but a small increase of blood ketones might promote a range of beneficial effects. And this is because particularly for beta hydroxybutyrate has been shown to interact with some specific pathways, you see here SCR2 and so on, to promote favorably anti-inflammatory lipid and appetite lowering effect. A number of dietetic strategies, for example, caloric restriction and fasting mimic diet, are also able to increase blood concentration of the ketones, and this diet has been shown to decrease a large range of intermediate metabolic and cardiovascular risk factors, including inflammatory parameters. So SGLT2 inhibitors have been demonstrated to foster mild ketonemia, with of course increasing the risk of diabetic ketoacidosis on one side, but the increase has been also been proposed to mediate the beneficial effect of SGLT2 on endpoints, particularly relative to heart failure to its bioenergetic properties. So we have a the need for a balance between a possible damaging effect in a huge increase of ketonemia by SGLT2 leading to diabetic ketoacidosis, but a small increase of ketosis of ketone bodies by the SGLT2 may have a beneficial effect on particularly on the cardiovascular disease and particularly on heart failure. The SGLT2 inhibitors induce increase in ketone bodies may also eventually underline the emerging anti-inflammatory effect of this class, and the anti-inflammatory effect of SGLT2 inhibitors might explain the cardiorenal protection observed in the randomized clinical trials, meaning the CVOT trials which have really changed the scenario of the diabetes management. Thank you very much for your attention.
Thank you, Professor Antonio Ceriello, for this elegant lecture, explaining some ideas about explaining the anti-inflammatory effect of SGLT2 inhibitors, which may be related to some production of ketone bodies. There is any question for Professor Antonio? Professor Khalifa?
Thank you very much, Professor Ceriello, for your nice talk. When we discussed the dietary instruction for patients with diabetes, to say that calculate the total calorie, then give 50 to 60% complex carbohydrates, and then the protein and fat, and so on. Do you think after this data or evidence, do we need to restrict carbohydrates in the guidelines for diabetic diet?
Thank you for this very intriguing question, which of course is translating what is emerging from the research in clinical recommendations. And I believe that today we have enough evidence that something has to be changed in our suggestion about the diet in diabetes. Not only in terms that maybe a major reduction in carbohydrates, you know, there was a very long debate about this, but maybe a reduction in carbohydrates could be beneficial. But I have to be honest, because I had the possibility to revise the literature about the intermittent fasting. I'm astonished how evidence is so strong, suggesting that this kind of approach to very sophisticated mechanism can influence the quality, the life of any human being. So one of the ways, because there is an increase of ketogenesis, of course. If the question is time to change diet suggestion, my short answer is, I'm sure that we have to revise something and to, according to the emerging literature, and to do something in this direction, which in my opinion is very complicated, because you have to impact on the habit of people, particularly in countries like your country, but also my country, in Italy. You know, we are consuming a lot of carbohydrates. So it will be not easy to convince people to have a less pleasant, because at the end of the day, a ketogenic diet is less pleasant than a diet plenty of carbohydrates.
Any other question, please? Professor Hisham?
Thank you, Professor Ceriello, for your presentation. I just want you to comment on the debate between cardiologists as regards the value of what we call it ketogenic diet, with different subtypes, and even non-professionals start to prescribe this diet. The cardiologist did not settle about the cardiovascular outcome of such diets with high lipids and so on.
Yeah, it's true. But you know that there is a huge debate about the ketogenic diet. I know this debate. Probably, I just show you that probably what was missing was the pathogenic, what I mean, the mechanism through which this kind of a diet can work or not, and also in the selection of the population. Probably what we really would need is a study in primary prevention more than in secondary prevention. Because when you introduce a dramatic change in diet in people already with a cardiovascular disease or with the advanced heart failure, it's very complicated to evaluate the effect of one single intervention and not having an idea of all the complete scenario. So for sure, I found several articles published in the European Heart Journal on Circulation showing that the ketones are good for the heart. So who knows what I mean? I think that is an intriguing situation which must be clarified, in my opinion, with a very high, well-designed trial in this setting.
Thank you again, Professor Ceriello.